Welcome to another edition of the Doc Suit podcast with Sharan and Mohit. We are two internal medicine residents exploring how healthcare, technology, and business intersect and influence each other. Today, we have with us Dr. Rahadwa, a seasoned healthcare innovation and transformation executive. Dr. Rahadwa started her career in healthcare admin in India at Infosys and then Accenture, eventually transitioning to the States with IKS Health as part of the foundation team. Currently, she serves as a senior vice president at Shearwater Health, a clinical process outsourcing enterprise based out of Boston. With over 22 years of experience in healthcare strategy, consulting, and implementation, she is the person you call when you want to drive a systemic change in healthcare. Thank you, Dr. Rahadwa, for joining us.
Thank you, Sharon, for that wonderful introduction. Appreciate you guys thinking about me and inviting me to this podcast. I want to start by saying applaud to both of you. I know uh, it's busy when you are doing your residency in internal medicine and thinking about this novel idea of how other physicians, budding physicians who want to make a transition in their career or just creating awareness of what is going on in the healthcare industry. Sometimes as physicians, we are like heads down just into our clinical space. So you guys are doing a great job by broadening that horizon for other professionals. So kudos to both of you.
We
Thank
appreciate
you
that,
so
ma'am.
much.
We appreciate that. So before we begin, ma'am, just wanted to ask you we're going to be talking about work, but what are things outside of work that interest you? Anything that you'd like to share with us so that we know that you're human as well, just like us.
Absolutely. Absolutely. I am not yet a robot, or nobody has cloned me yet. So
Yet.
outside of work, I love playing with my dog, Bruno. I love traveling. As a family, we travel a lot. I love hiking. I have a little bit of artistic side, so I do some artwork. And then I love reading whenever I get a chance. For me, curiosity keeps me going. So
That's great. That's awesome. I think
That's
I can see
great.
some artwork in the background as well. I don't know if that's something you painted, but
I have not. That's my inspiration. That's Mount Kailash. I
I
keep
see.
it because I want to visit someday. So
I see.
Wow,
it
beautiful.
keeps reminding me. Yeah.
I
Beautiful.
tried pottery once. It was the worst experience ever. It didn't turn out to be a pot.
There's always that first time, right? You just need to keep
Yeah,
going.
All right,
definitely.
so diving right in, briefly, can you tell us about your roles at Infosys, Accenture, and then IKS Health? And having worked across industries across the globe, can any fundamental pearls that you think were consistently useful in these areas?
Sure. So even before Infosys, I started my career as a clinician, just like you guys, worked for almost 3 years and then quickly pivoted to healthcare administration as a hospital administrator. I felt that my potential was more when I work as a team versus individual contributor.
Yeah.
I was there for a few years, loved the OB-GYN setting because I was passionate about OB-GYN in particular and holding that new life in your hands. That's the greatest joy that you can get. So did that for a few years, and then somewhere I felt that to make that next move in my career, I need to have my post-graduation or master's, and that's where I started exploring. Tata Institute came across,
Yeah.
and I got fortunate to be selected out of the 30 people across India and got into the Masters of Hospital Administration 2008, completed, and then I started my corporate journey, I would say, with Infosys as a hospital consultant there. Worked with US healthcare payers and providers, the Middle East as well. And then I moved to Accenture, which was more strategic management consulting. Again, broadened my horizon across different countries, continents, working both on payer and provider side. And then IKS was another big journey of 9 years where I was in multiple roles, started as a director of clinical solutions, part of the foundational team. That's where I got introduced to Mass General Brigham, the client that I worked for 8 years. And the primary goal, the part of that foundation team was how do you alleviate the administrative burden for physicians who work
Hmm.
day in and out? How do you let them focus on patient care and take care of all the other work that they have to do?
Right.
Started as director of clinical solutions, then quickly moved into implementation, client facing, and then became the market leader where I was not just implementing solutions, but co-creating solutions with Mass General Brigham. We had exclusive arrangement with them. We still do. So it has been an enriching journey. And then September 2023 came in Shearwater, and again, one of the best decisions of my life to join Shearwater as a senior vice president of the provider vertical. And we'll talk a little bit more about the company itself.
Yeah.
So that journey, if I look back as a physician and now where I kind of lead that healthcare transformation, has been really gratifying and humbling journey. One thing that I would say is consistency and hard work. There's no shortcut to hard work. I would also say that when you are in the moment, you feel like this is a mundane job that you might be doing or something that may not so exciting, may not be so exciting. I think the key is take every experience, give it your 100%. And when you look back, you will realize that 1 month experience, that 1 week project still has some impact on what you do today. So, when you feel like the journey has been long, but it's not yet giving you the results that you expected, you have to be patient and keep working towards your goal. I also believe as long as you're passionate about what you do, whether you're in a clinic seeing patients or you're leading a healthcare transformation vertical like mine, the end goal, the passion of improving healthcare outcomes has been still the same. And as long as you stick to that passion that you have, I think success is inevitable.
I think taking it like one day at a
Wow.
time, that's something I feel like it applies to both Mohit and I as well with residency. It can get it gets very tiring at times, like you said, and I think sort of even though we've heard this a million times, every time we hear it, it's like another reminder that okay, there must be light at the end of the tunnel if so many people are telling us.
That's right.
Definitely. Definitely. There is, I mean, I think so. It's a test of our patience, persistence, enthusiasm, discipline, residency in particular. But what I must say is, Dr. Radhava, you have had immense experience across the whole transformation journey. Um, so I had a few questions. So when you were in your whole journey of in the administration aspect, were you mostly involved in the digital transformation aspect or payer and provider aspect? So what is the difference between these multiple terms that are being used globally?
Great question, Mohit. So, providers in the US healthcare context is any healthcare organization that provides care, right? That provides patient services or clinical services. It could be a large academic health center like yours. It could be a physician group where maybe 200, 300 physicians come together. It could be a home health agency that is catering to the needs of people who need home health, hospice. So these are different players. You could be an independent kind of, provider in the market. You could be an integrated healthcare delivery system, which is a new term, right? Which is a conglomeration of payer and provider. Optum is a classic example of that. So that's the provider space. When you say payer in our India healthcare context, it is your insurance companies, right? The
Right.
health plans.
Right.
That's the payer industry that makes sure that the providers get paid for what they have done. Now, in US, it's heavily driven by insurance.
Sure.
91% of the people have some form and fashion of insurance.
Mm,
So that's your payer world, they still have their own administrative kind of, wings, enrollment, patient enrollment, disease management, chronic disease management, provider credentialing, provider data management. So that's your payer space.
Okay,
Your
these are
question, yeah, please.
these are two different industries, I feel.
That's right.
Yeah.
That's right. To add
Sorry for
another
cutting off.
layer,
Yeah.
there is pharmacy benefits management. So within
Yes.
insurance, you will
Yeah.
have your traditional health plans, and then you will have PBMs. CMS has their own Medicare, Medicaid programs, right? That are in some form and fashion subsidy or government insurance plans, for lack of better term.
Right.
Makes sense. And sorry,
Yeah.
please go on.
Your question about what have I done in these spaces throughout my career. So it's been a mix, I will say, but for the last decade or so, my experience has been primarily in the provider space. It has some overlap with the payer when it comes to coding and reimbursement, but primarily catering to the provider space for the last decade or so.
That makes sense. So mostly towards the digital transformation space, I would assume, if I'm not wrong.
It's a mix, I would say. Again, my IKS experience and Shearwater experience has been more service oriented, which is providing services. Digital, I would say, primarily was with Accenture when we were talking of care coordination, digital health. So technology, I don't see, I never see technology as a standalone. I always see that as an enabling strategy for your core goal.
Yeah.
That's how I see it. So it's always sprinkled, whether you're making your own teams efficient or you're using technology for enabling your service.
It's a tool, right? It's a tool.
Exactly.
It's not like it's gonna solve something on its own. It's you all need to have like the solution in your head, and then this streamlines it and scales it. Like that's what technology does.
That's right. That's right.
Yes.
Take away the mundane task and then make sure that your associates, your workforce is operating on the top of their license. Now, automation has been there for decades now. It has come into healthcare recently and rapidly. What we need to make sure is that we don't swing the pendulum too far
much.
and take it as a shiny object. There has to be a lot of regulatory compliance cadence before you can implement any solution.
Yes,
That is so
definitely.
interesting. Yeah.
So when you came to Shearwater, what I believe it is a clinical process outsourcing enterprise. Can you tell us in simple terms, like what are the problems that are faced by healthcare in general that actually require a clinical process outsourcing company or something? Or what problems do you solve in general, and how do you really do it?
Sure, that's a great question, Mohit, again. So just to be clear, CPO stands for Clinical Process Outsourcing. It's a proprietary term that was coined by Shearwater back in 2009. So, simple terms, outsourcing, anything that is delegated outside the organization is outsourcing. It has been there for almost 5 decades, I would say, outsourcing in general. And it started with manufacturing industry, where they wanted to cut the labor costs, so they outsourced some of that production work. In healthcare, I would say outsourcing started probably in the late 80s, early 90s. I'm not wrong. So it's been there for almost 3+ decades or so. What clients come to us? So talking of CPO, we have 3 verticals within Shearwater. We have the provider vertical, we have the payer vertical, and we have something called workers' comp and disability, workers' compensation and disability. I lead the provider vertical. So typically, when provider clients have scalability issues, they have staff shortage, they are looking at streamlining processes, standardizing processes, when they look at cost efficiency. So I'm sure you may know, and our viewers may know, that there's a lot of pressure from CMS on operating margins for the providers, right? There's a lot of cut in reimbursements, right? So there is obviously that cost efficiency factor. There is staff shortage. Pandemic has not helped us in that sense. You know that in the next 5 years or so, there'll be a shortage of almost 125K physicians. Why? Because there is high burnout. The latest study, I think that came in April, said that 45% of the physicians are burnt out. It was 65% in 2021 when the pandemic was probably at its tail end. And people just want to leave this profession because of the heavy administrative burden. We have nurse shortage. 62% of the hospitals today have 7.5% higher vacancy for nurses. There is an aging population that is going to increase the demand, right? So these problems, and then there is this, every location has their own way of doing things. So there is no standardization across the board. So all of these problems lead to companies like Shearwater, where we can come in, we can be, think of CPO like having a pit crew for your clinical team, quietly working behind the scenes, making sure every process runs smoothly, it runs faster and more efficiently from a cost perspective, so that your clinical team can stay focused on patient care and we take care of everything else, whether it's clinical in nature or administrative in nature. We are unique in a sense because we have 80% of our workforce that is clinician. So
Interesting.
that credibility, that empathy already comes. We know because we have been there. We know what it means when the patient is ready for discharge, but the discharge documents are not ready. The coordination is not being done, whether it's home health or the patient is going home. What happens? Who is picking up the patient? Are the meds filled in? Like, there are so many processes that go in that we may not be aware when you look at the surface, but there is a lot that goes on. So we take care of all of that burden. We are unique in the sense because we are clinical focused. So we are not a typical outsourcing shop. We only focus on highly complex clinical workflows. So I hope that answers your question, Mohit.
Yeah, very, very well phrased. And I like the example you had given.
I think the additional the thing that I didn't know is you guys are 80%, like 80% of your staff is clinical or clinicians, and I think that's important because it's coming from like me, and I'm sure Mohit would agree to this, that when people outside, people who've not trained in medicine come in and comment about medicine, um, it becomes obvious. It kind of becomes obvious, and then it's very hard to trust them because there are certain things that you will only know if you've spent at least like a year or 2 years in the hospital taking care of patients, as opposed to spending a week with somebody or having 5 meetings. That is not going to like that domain experience is necessary.
Absolutely.
And when it comes, when solutions like this come from people who've trained in medicine and then they talk about this stuff, it allows us to trust them much more.
Exactly.
But yeah, I think honestly, I think that one answer we can dive in and dig deep and make a three episode podcast out of it if you want. But we'll keep moving. So I understand that bedside nursing is also an important vertical. That's something that I found interesting. Could you explain to us and the viewers how the SOP of how that looks like? Point A to point Z for both the nurses that are being staffed and the employers that are staffing them.
Yeah, you asked a great question that is close to my heart. I don't know if you guys know that last week we celebrated the Nurses Week, right?
Yes.
Yeah.
Yes.
So bedside nursing to me and to Shearwater is not a job, it's a journey. And that was the theme of our celebration, Road to Remarkable, Your Journey, Your Impact. What I mean by that is the journey is rarely simple. It's a journey, by sacrifice, ambition, and extraordinary commitment. We place international nurses from 38 plus countries at bedside for US health organizations or providers. Before they come to the US, I think there's a wait of at least 4 to 5 years. I had one nurse who came from India. She waited for 13 years for that journey. And you can imagine the commitment and the passion that nurse had to fulfill her dream to come here. So behind that journey, it begins with that passion, with that calling to care, and it continues through clinical training, the NCLEX, certification, all the immigration process, the ills of the world to make sure they are ready, the credentialing, the licensure requirement in that particular state. So it's a journey. It's a life-changing event for the nurses because we are not just talking of that nurse. We are talking of the nurse, their family, and the generations to come. So we are immensely proud of that vertical, apart from the CPO vertical, because it reflects the strength and dedication of the nurses who cross oceans not just to work, but make a difference in the healthcare setting.
But so what, can you explain to me why somebody would have to wait 5 years? You said on average it's 5 years, right? So is it because of the costs involved? Is it the exams that they have to give? Is it the immigration backlog? What's what's the bottleneck?
You mentioned it, right? It's the immigration backlog. Well, there is a process, and we also want to make sure that even though they come with their local experience, we want to make sure they are set up for success when they come on the US bedside, because you may very well know that the US healthcare clinical practice is very different from what you see. So primarily immigration backlog. However, the way we partner and the way CPO and bedside nursing are woven together, the nurses are not just sitting there. They are enhancing their clinical knowledge. They are also working on the CPO side so that they gain that experience. They understand behind the scenes. And when they come here, they are much more efficient.
They hit the ground running, essentially.
I'm sorry?
They hit the ground running,
That's right.
essentially.
That's right.
The
And
nurses over here are actually very well trained when comparing globally. And they do know more about the patient in terms of how they look clinically. They can actually assess if the patient is deteriorating or not, or stable, and what to do, how to do, and also give suggestions to doctors. So immensely, they work as a team, in the US, where there's a doctor and there's a nurse, and I think so. It has been very beneficial for patient care and what to do next.
And they also bring in their global experience. So 80% of our nurses are Filipino nurses who are known for their patient care, who are known for their dedication and compassion. So they bring the global experience as well as they gel well with the US kind of way of working, and they are ready. So we have simulation labs. We have a lot of investment in training our nurses that make them ready when they come here, and they get excellent feedback.
That's wonderful. So one question that always was in my mind is, so as a physician, we often really don't think about admin work, especially in larger setups, where we have an adequate approach. What are the barriers you have actually encountered when working with physicians? For instance, if a physician is transitioning to healthcare administration, he has mostly been focused on clinical work that's very superficial still, not in depth or back-end work. So I just want to understand the barriers and the hurdles that you've actually faced when communicating with physician in general from a clinical improvement process point of view.
Yeah, we are physicians here. I will admit it's very hard to change physician behavior in general. Physicians, But I will say most of them. I don't want to say all, but most of them are like that. And that's how we are trained, right? To be precise, to be evidence-based. We
Mhm.
don't believe until we see it, right? And we are skeptical, which is a good thing in medicine because we are treating patients, right? We treat patients. But it can slow down change when it comes to administrative changes or something that changes the workflow. I think same thing holds true for nurses because that's how we are trained. That's how we have embraced, right? But I think change can be only embraced when it is proven, practical, and personal. So the key when you want to change any workflow, when you want to bring in some change, the key is listening first, showing value or ROI quickly, and never forgetting that, behind every workflow, there's that human being, whether it's a nurse or a physician, who's doing their best for the patient. That's their intent. And this can only happen if you have been on the other side of the table, right? That empathy can only come when you have been through that. So that's where our team can quickly build credibility because we speak the same language. I have worked with National and many other organizations. Being a physician and being in that room changes the dynamics because they know that I know what they have been going through or what they have
Exactly.
gone through and what is the thought process coming behind that. So that is critical. Building that credibility and partnership is the key to success. I will also say this, that getting the buy-in from all the stakeholders is very critical. So if I have a solution that is going to, let's say, alleviate the documentation burden for physicians or for nurses, it's going to remove some of the things that it will allow face-to-face care. It's not just about that physician or that nurse. You have to make sure that the clinical leadership is bought in. You have to make sure that the CFOs of the world understand the financial ROI. So talking to each stakeholder and making sure what is in it for me is very important. And that inside out perspective only comes by experience and by being in that place.
Yeah, very good example. Let me take a very simple problem, medication reconciliation. That's a workflow in general. So what we do is we call the pharmacy, ask the patient don't know their medications because there's a lot.
Yeah.
And then there's a lot of inefficiency in that process. So a physician would give you this problem, then you would sit with the physician and you'll actually plot the whole map on a whiteboard, and then you will decide where can something be integrated to improve the efficiency, if I'm not wrong. That is what is clinical workflow, right?
Yeah. So for example, you take the same example of medication reconciliation, right? So instead of the physician going through each medication and validating that with the patient, can one of my clinicians take that work and validate that information and provide you the side-to-side comparison saying this is what you prescribe, but this is what the patient is taking. Here is the change and here is the final recommendation. You will still be signing off the final reconciliation, but instead of gathering that data from scratch, if we help you with that without changing the protocol, following guidelines that will be co-created with your team and Shearwater team, but still giving you the confidence that everything is finally checked by you. But you don't have to be the one who is preparing all that data. That's a good example.
It's interesting. So it's like it's almost as if you're, again, like you said, you're not recreating the wheel. The wheel's already rolling. You're just making sure all the spokes are working correctly and it's well balanced.
Yeah.
And all right, that's amazing.
Yeah, let's take another example, which is more nursing oriented, is virtual case management. So you guys may be familiar with case management team. There's a case manager. When the patient is admitted in the hospital, there is a transition care planning assessment that gets done within 24 hours, 48 hours of admission, right? Now, instead of having an on-site case manager do this work, by the way, 50% of the case managers are at the age of retirement. So there'll be that case management
Yeah.
kind of shortage that is going to hit us. But instead of having that on-site case manager do that TPA, our nurses get on the phone with the patient or their relative, complete that TPA assessment, document that in the EMR so that the on-site case manager can focus more on face-to-face cases or discharge planning or whatever. So that's another
Mm,
example of following the same process. And in that process, we also look at it critically to see, is there any non-value add? Is there any opportunity to standardize this workflow? Is there any
Mm.
opportunity to re-engineer, optimize that workflow so that we get the same result without compromising quality?
makes sense. Wonderfully summarized, wonderfully given. Now I understand the whole thing, whole process in general. One question I had is, what do you see opportunities in the administrative aspect or artificial intelligence perspective? Because what I feel is healthcare
Everywhere.
admin is a low-hanging fruit compared to, let's say, integrating AI into the more clinical processes in general. So, where do you see the next few years going in terms of opportunities in healthcare administration?
So I will say this, that you touched upon two topics which may be correlated, but I still see them as separate, is healthcare administration in the next few years, right? So it's a very broad term, but I will speak through it more from a capacity standpoint.
Mm.
So it's at that inflection point is that where we have physician shortage, we have aging population, the life expectancy has grown. There is this cost pressure, um, and there is this burnout. So while we have all these issues, if we don't think as a team, if we don't think of care coordination, not just the physician, not just the nurse, but seeing as a holistic team, if we don't think of creative solutions to operate on top of the license, whether it's doctors, whether it's nurses, whether it's case managers, or anyone in that um, administrative capacity, we will, this is like crisis in the making in the
Right.
next few years. So you have to think out of the box, you have to be innovative in that sense.
Mhm.
Now, the good news is that you have AI coming in. I like to believe it's not artificial intelligence, it's augmented intelligence, which is meaning in healthcare. Think of this, when you pick up the phone and when you hear that automated voice or that robot, right? You want to talk to someone human. So while it will help, augmented intelligence will help take care of some of the mundane tasks. Again, it has to be very thoughtful. We have to make sure we are dealing with patient lives here. So we have to make sure that the process doesn't get broken, the data doesn't go out, there is compliance, regulatory kind of cadence there. Um, but also communicating, whether it's our own internal clinical teams, administrative teams, or even the patients, that it is not replacing humans. It is enabling humans to be more efficient.
Mhm.
I
Yeah.
think that's the key. Um, Otherwise, again, we'll be wasting this great tool, which is AI, where people will lose trust, and that we don't want that.
You're saying it
Definitely.
can swing either way. If the pendulum swings too far to the artificial side, we're going to end up with human beings saying, oh, we don't trust this at all, and they're going to go the other way. Versus we do it in a more, we integrate AI more slowly, methodically, more thoughtfully, and gradually,
Mhm.
and allow for like humanity in general to kind of accept the new reality that this is going to be part of our day to day.
Yeah. There has to be human in the loop always, I feel, in this whole AI process. Let me give you an example. So we have bots, right? RPA, robotic process automation.
Sure.
So from a prior auth perspective, if you give it the task of going and checking every day on the payer website to see if that prior auth has been approved, that's a very simple task that can be easily automated.
Automated, yeah.
You still need human in the loop or human intervention to see if that approval has not gone through for the last 3 days. You have to
Why?
pick up the phone and
Yeah,
call, right?
yeah, yeah.
Mhm.
So I will say that we are at a nascent stage in terms of augmented intelligence or AI, in that sense, where there's a lot of regulatory work that still needs to happen before we can say, yes, you can do this. But I think that human touch, that clinical touch will still always remain.
Yeah.
Coming back to that example for a second. So just for that specific example, what you were saying essentially is uh, work like this, mundane work like this, which let's say would require three human beings right now to do, could be done with one human being and augmented intelligence.
Yeah.
But what you are actually saying is those two human beings are not going to be looking for a job because the amount of work that's pending and that's coming on our way because of the aging population, the costs and the
Yeah.
all of that, like those two people are also going to have a job. It's just our capacity to work and the amount of work we'll be doing, both are increasing synchronously.
That very well said. You summarized
Mhm.
it well. That's exactly
Okay.
the case. So it's not a threat, I would say. It's
Okay.
how we use it to our benefit is the
I
way.
imagine, I imagine what if we didn't encounter AI and like because we're still going to have this increasing workload, right? What if in an alternative future we never came across generative intelligence and then what would that or artificial intelligence, how would that look like? That'd be a fun what if episode. All right, so moving on. So the healthcare systems, I think all three of us have had experience in both in India and now some experience in the US, I like to say, as a first year resident. But they're designed very differently and they're designed to serve the unique needs of their people as well as their administrative setups, right? So, what is one thing each can learn from the other from a health admin, from specifically from a health admin standpoint? Like, what does the US do really well in terms of health admin, and what does India do really well that the US can learn from?
Yeah. Again, great question. I will say that you rightly said that it's not fair to compare both
Yeah,
systems because of
yeah,
the geography, because of the patient population, and just the resources that you have. But
yeah,
there's always opportunity for cross-pollination, right?
yeah.
So if I think of India, what we do well, or Indian healthcare system does well, is I think the cost efficiency. So you know that we spend probably 3 to 4% of our GDP in
Yep.
India versus in the US, it is 18% of the GDP, which is almost 3 trillion, right?
Mhm.
Correct.
So cost efficiency, low cost healthcare models is something that probably US can learn from India. Classic example would be Arvind Eye Care, Shankar Netralaya, where
Yeah, of
they have these low cost surgeries
course.
without compromising on quality, but are still able to optimize their workflow. The way they work is amazing.
Yeah, of course.
The other thing I would say is maybe public-private partnerships that India has, whether it is infrastructure-based or tech service-based or through insurance or through capacity building. I think that collaboration of Indian government with these private players, whether it's Manipal model with Kasturba Hospital,
Yeah,
or it's the e-Sanjeevani telemedicine
yeah,
model or Ayushman Bharat, right? So
yeah.
there are multiple examples that probably US can learn from Indian healthcare system. If I flip, what can India learn from US? I think US healthcare does a great job in terms of keeping the patient at the center, right? The patient-centered care model where everything revolves around the patient. There's a care coordination team, there's your PCP, there's your specialist, there's your case manager, there's
I
your
see what you mean.
social worker. In
Yeah,
Yeah.
India, I would say majority of the times, it's the physician where everything revolves around, right?
Yeah.
So I think that's
Interesting.
one great learning that can be taken. The other thing I would say is insurance. I mentioned the statistics that 91% of the people here in the US are under insurance umbrella. In India, it's still 25%. And that 25%, I can confidently say, is coming from employer-based insurance, right?
Definitely.
That awareness is still not there. So that will really help drive a lot of the infrastructure and the cost and the healthcare debt that a common man faces in India.
But LIC has been in the country for more than 50 years, ever since India was created. So why aren't Indians actually buying insurance in general? And the government has actually spent a lot on awareness. That's what
Mhm.
I feel. I'm just trying to understand what's wrong with the mindset of
I don't
buying
think it's a
insurance.
mindset issue. I think like we sometimes forget that India is still like 90% Bharat and 10% India. And we like I think keeping that in perspective, keeping the fact that India is like a very young country still and how far we've come, uh, given that like three generations above we were still under colonial rule, and in three generations we've flipped the table. We're doing
Mhm.
as much as we are. But sure, there are. I mean, that again, like you said, you can't really compare
Yeah,
two
true.
different models. But it would be fun to see like why. Like it would be fun to take that up as a problem and sort of deconstruct it and see where we can sort of drive change there.
Yeah.
I want to say one last point about this is the regulatory framework and
Hmm.
accountability, right? That the same cataract surgery can cost you maybe 5,000 rupees versus 50,000 rupees, depending on where you do. So that price regulation framework is still missing in India. That also probably is a hurdle in having that insurance, right? I believe.
Mm.
Sure. No,
So
sure. I agree. Yeah.
So, Dr. Radhawa, I have a last question, and the last question is, what do you see in the next 5 years medicine will look like?
again, a very loaded and a broad
That's
question.
how we do it.
It's a
That's how we
it's
do
a
it.
jam-packed podcast.
Again, as I said, I can speak more from a capacity standpoint because that's where the space I live and breathe in is.
Mm.
I believe that we need a smarter system that can allow physicians like you to focus on patient care. We need to provide you support. You guys didn't go to med school to learn coding. You guys didn't go there.
Yeah.
Probably it's also a calling that the healthcare education needs to be to broaden their curriculum to make sure that the physicians are not just heads down into clinical, at least they have the awareness of the large
Yes.
healthcare ecosystem. So think of healthcare as a body in motion. You guys are the brain, physicians
Mhm.
are the brain, and nurses are the heartbeat or the heart, right? You can have the brilliant brains and you can have the strongest heart. But if you don't have other things working, then the body is going to stumble. If your brain is foggy, i.e., the physicians are burnt out, your body is not going to function the way it is.
Absolutely.
So, collaboration is the key to
Mhm.
succeed here. You will also need external help like vitamins,
Mm.
coaching from companies like Shearwater to run this healthcare system, you know. So, unless and until we get out of that traditional mindset of how medicine is practiced, how healthcare organizations run, the future with all the cost pressure, with all the staff shortage, nurse shortage, and just the operating margins going down and the
Mhm.
aging population. Other big area which I feel is how do you use AI? We spoke about it at
Mm.
length, cautious use of AI to combat some of that shortage, and then looking at solutions like us. And then the last thing I will say is home health. So the burden right now is a lot on tertiary care. Everybody wants to go to the hospital. How do you segregate? How do you make sure the PCP model is working as the hub and spoke? You go to specialist with some
Hmm.
specific guardrails. You go to the next level. How do you create that community health care model that will reduce that burden on tertiary care? How do you home health is going to grow significantly. I think the last numbers that I saw was like a 450 billion opportunity in the next 5 or 6 years, which is basically reducing that burden, providing more bed capacity for the hospitals that can cater to the sicker population and make sure that the home health agencies take over something that doesn't actually need hospitalization. So
Mhm. Yeah. So
innovative
take,
and
sorry,
yeah,
go ahead.
no, I was just going to wrap up with innovative and transformation thinking is required to change or to cater to, otherwise we are calling for a crisis. Go ahead, Sharon.
Yeah. So taking basically healthcare outside of the hospital, I think uh, I love that analogy that you made of, the physicians being the brain and the nurses being the heart. And like, I think that's kind of what Mohit and I are trying to do with this podcast, where we are trying to like reach out to people outside of healthcare, because I think we have understood very early on, even before we started residency, that this is not an isolated like medicine cannot function and does not function as an isolated, in its own vacuum sort of. It is dependent, and it functions very, very, very closely with a lot of different um, domains and people from other vocations, and it's important for us to understand how that happens
Mm-hmm.
and take like a zoomed out view. um, and following on that, so I know you mentioned that Shearwater does employ clinicians also, but do you think there is a space in this industry for someone who's trained in medicine to leverage their clinical experience and drive change at a systemic level as opposed to one patient at a time? And if so, how would that journey look like for somebody, say, in residency?
Absolutely. Great question. I'm a living example of this journey, right? So, absolutely, if I can do it, anyone can do it. Um, I think most important, Sharon, is the passion. What do you want to do? What is your goal? What gives you that calling? What gives you that meaning or goal for life, right? That is critical. Patient care, healthcare outcomes, if that's your goal, you can do it in multiple ways. You can continue doing your clinical work. There are multiple tracks, not just Shearwater, but multiple tracks that you can go. You can go into healthcare administration, keep growing the ladder there, and still be able to impact in that way. You can take the payer track. We do a lot of UR work, utilization management, utilization review work, where you need that clinical acumen. When we started this podcast, we talked about credibility, we talked about being there, right? If
Hmm.
you have done that, been there, that's what we need. We need those SMEs, subject matter experts, functional
Correct.
expertise that you have done that so that you can create a solution that will make sense. You can create a fancy UI for someone like an interface, but if it's not usable, if the physician doesn't get what it needs, if it doesn't meet the needs,
What is
you
the
can
point?
create whatsoever, but that's not going to work. Now, that functional design can only come from a lens of a physician. So,
Mm,
that's the value that you bring to the table,
Hmm.
whether it's payer, provider, or companies like Shearwater, where we design those solutions that can meet the need of our clients.
got it.
Very well explained.
But yeah, I
Very well
think
explained.
I think that's all the questions we had for the episode. Like I said, I think if we start exploring this, the three of us can start a series and have our own podcast. That's how rich this content is. Um, Thank you so much for joining us, Dr. Rahadwa. I think this was a very illuminating and insightful discussion. And I'm
Likewise.
sure you agree, Mohit.
Definitely, I agree. I think so. It has given us a very different perspective, a very clear insight on multiple aspects of the industries, how they're functioning together to actually deliver care to us, it's a very well summarized podcast, but still the tip of the iceberg.
Thank you for this opportunity. I enjoyed this conversation. Keep doing the good work. Looking forward to more interactions in the future. And keep doing what you do the best, patient care.
Thank you, ma'am.